Good morning, everyone. I'm Dr. Shaglov, an infectious disease epidemiologist with the DCD clinic, presenting today information on the recent outbreak of infectious pseudo-1 flu virus. This virus has flu-like symptoms, but it's more invasive with no vaccination yet developed. The current standard diagnostic test to differentiate it from regular flu virus requires injecting patients with an intravenous dye. The injection with dye is not suitable for everyone, and it can cause nephrotoxicity, especially in geriatric and cardiovascular patients. For this reason, we at DCD Clinic developed an alternative diagnostic tool which requires only collecting phlegm sample from our patient. We sampled 10,000 patients. The prevalence of the pseudo-1 virus in our selected sample is 14%. This is relatively good, but we need to evaluate the strength of our test more. First, we will look at the columns in our 2x2 table. Calculating the sensitivity, we have 1,400 confirmed to have the virus and 1,274 of them tested positive, which means the probability for the patient to test positive for the virus, given that they have it, is 91%. As a clinician, explaining this to your patient means that the test is strong and sensitive for providing a true positive result. The specificity is calculated as the patients who are negative and tested negative, the true negative. This equals 15.78%. This is not very high. It is essentially stating that people who do not have the virus, there is a 15.78 chances that the test will be negative. With larger sample population, a further testing of our diagnostic tool, this might change to a higher number. Overall, these are very good results, but we have significantly more false positives than true positives. So we need to examine the positive and the negative predictive values. To do this, we look horizontally at our rows in the 2x2 table. It is important to note that here we collected our data in prospective manner so that the positive and the negative predictive values have meaning. The positive predictive value identifies the patient who tested positive. Out of the 8,517 who are positive, only 14.96% will have the pseudo-1 virus, the true positives. This is the probability that patient who have the virus and test positive for it. This is a low rate for the confidence of the test, in the contrast to the strong sensitivity of the test. The negative predictive value identifies out of the 1,493 negative patients, only 1,357 or 91.5% will not get the disease. This is the probability that the disease is not present and the test result is negative, the true negatives. You can explain to your patients that we are 91.5% certain that they do not have the disease or the virus. It is good to explain this predictive value to your patient, both considering the test and who have completed the test. These measures validate the use of our p-test for the pseudo-1 virus over the intravenous dye injection as a diagnostic tool. As a clinician, you are encouraged to use multiple tests and diagnostic tool. It is important that you share with your patients the risk of each diagnostic tool and how it may or may not aid in correct diagnosis. A good physical exam is also vital and never to be missed as a primary diagnostic tool. Thank you for your time this morning. Do you have any questions? If you have follow-up questions, I can be reached at shaglov@dcdclinics.com.